She has forwarded the number to you. Oh, she's not getting. She's not getting the call.
Nine double five.
Hmm?
955 30 9500. Dr. Ramapur.
Good morning, Dr. Annapurna. I am Dr. Manila, Director of the Manapur Medical College. And we are waiting for you to join. Okay. YouTube is coming. You can put OK.
Yes, sir.
You will join now.
So I can share this link to Flickr reference. She wants recording.
Yeah. Sir, good morning. I will ask her to call you, sir. Okay.
Morning, sir.
Sadanand? Sadanand? Huh?
It's not his name.
You call. Good morning, madam.
Good morning, sir. How are you, sir?
Without that, she will be able to talk more.
అవును సార్. థ్యాంక్ యూ సార్. మేము లేదండి సార్ ఉన్నాను. అవును చేసి ఓకే ఓకే సార్ థ్యాంక్ యూ.
You
చికెన్ షేప్
Madam, you share the PPT and see how it is coming.
1 minute, sir. I'll share it. Yeah.
It is visible. Where start? This is visible.
Okay, sir. Yeah.
Good morning, Dr. Annapurna.
Good morning, sir. Very good morning.
Good morning, everybody. I am Director Ramana Homoeopathy Medical College and Hospital Sangareddy, one of the prime institute in India. We are having our NEXUS 2025 webinar series. This is 63rd webinar of the NEXUS series. We are national seminars and international seminars. We are in association with the SAFIA, School of Pharmacy, Homeopathy, Forensics and others from Kerala. Today we are having a very enlightened speaker, Dr. Annapurna Yamanaru, and practice of medicine expert. She is a homeopathic student of Hyderabad. She is in practice since last 14 years with experience in treating many female skin and pediatric complaints. Currently, she is working as homeopathic consultant and assistant professor at Headquarters National Institute for the Development of Intellectually Handicapped Persons. Second year, past 4 years. She is a central government run. This is a central government Indian Supervision Center comprised for psychologists, special educators, therapists, psychiatrists, pediatricians, pediatric neurologists, orthopedic surgeons and dentists, and the umbrella for the treatment of persons with neuro developmental disorders. During her tenure, she acquired a requisite experience towards the diagnostic clinical homeopathic approach for the management of cases like ADHD, ADHD, CPID, development delays, Down syndrome, behavioral disorders in children, epilepsy, and other rare genetic disorders are managing other comorbid issues in these children. She is an expert also. She is the member of YTT 200 Yoga Alliance USA, basic yoga teacher, training courses. She is council person, Joint Secretary, Homeopathic Medical Association of Telangana, executive committee member of Indian Institute of Homeopathic Physicians, Director Hyderabad, recognition, first prize in national level case presentation competition of cases kid and body cancers approach in the year 2010. Second prize in painting competition organized by the homeopathic healers worldwide in the year 2015. Award by an international state 2015. She is presenting the homeopathy taking ADHD cases. Welcome, madam. Now the forum is yours. Thank you.
Thank you so much, sir, for the wonderful introduction. First of all, excuse me for the bad throat today. Next, I would take a moment to appreciate and to share my gratitude to the for getting this opportunity to present as a speaker on the prestigious platform of MNR Homeopathic Medical College, sir. Thank you so much. I would like to thank Dr. Maninal S. Sir, Director, MNR HMC, Dr. P. Venkateshwar Rao Sir Garu, Principal MNR HMC, and Dr. Pavitran, who is the coordinator for the event. And last but not the least, Dr. Sneha, HOD and Professor, Repertory Department, who has been kind enough to invite me for this session. Thank you so much, everyone. And I would like to welcome all of you to today's presentation. And today I'm going to talk about the role of homeopathy in treating ADHD. So, so to begin with, how common is ADHD today? So ADHD, my fifth class son comes and tells me, Mom, one of child in the class is having ADHD. So that is how common ADHD is today. The awareness has increased a lot. The rate of diagnosis has definitely gone up. Along with that, the expertise needed, the research which is going on has also improved a lot in all fields. So let us all begin this journey of unveiling each aspect of ADHD to get a broader picture of what ADHD exactly is. So this is what we are going to navigate through. Let us learn about what is ADHD. Okay. So what are the risks? I can't hear you, sir. So next, we would like to move on and we would navigate through these points. What is ADHD? So unless we have a strong foundation of what ADHD is, then we can build the apartment on it, right? So how to manage it and how to manage it homeopathically. So what is ADHD? What are the risk factors of ADHD? How do we diagnose ADHD? What are the different therapeutic options those are available now? What are the goals of therapy? What is the homeopathic approach? Which are the commonly used homeopathic drugs? And a few case studies. So let us all begin this journey with me today. So, so typically what happens is parents who come to the clinic, right? So parents who come, they generally come with the presentation. So what is the presentation of these children? Parents will generally say, oh, my child is very hyper. They call it hyper. So what is that hyper exactly? That the child is not sitting in one place. He keeps on roaming from place to place. He is not paying attention to what he is doing, right? So that is the presentation. They never get tired. I'm sorry for the disturbance. So what are the, so they never get tired. There is excessive impulsiveness, destructive tendencies. They throw tantrums. We cannot take them anywhere because as soon as they see something and they don't get it, they start throwing tantrums then and there. So that is very embarrassing for the parents, right? It is difficult for us to engage or manage them. They get unusually aggressive during tantrums. Okay. So what is the parent is coming to us with? They say, please reduce this hyper, doctor, right? They remain active past sleep time. This is another major issue in these children. They are having so much energy that they do not sleep in spite of getting tired. That is what they say. They don't get tired. They seem to have so much energy, doctor. And they become difficult and unmanageable at bedtime. And they're usually very restless. And we have changed the schools many times because they are not allowing him in school. This is another major issue, academics and behavior, social behavior at the school, for which the parents run to us, right? He is not cooperative for therapies. Okay, so what is the general treatment for this? They are asked to go for therapies, but the therapists send them back saying that you first reduce his hyper and then we will start therapies with him. So this is the basic presentation with which the parents of these children will often visit us, right? So what is ADHD then? ADHD is a neurodevelopmental disorder. So it is one of the disorder which is a part of the spectrum known as neurodevelopmental disorders. It is a condition which makes it difficult for the children to control their behaviors or to pay attention, right? They cannot control their behaviors. It is a kind of impulsiveness or the hyper behavior, right? and they are not able to pay attention. So, how was the onset of symptoms? The condition often becomes apparent when the child is in preschool or early school years. Till then, the parents notice it, but they oversee it. They say the child, they are children, they do like this. But once he starts going to school, that is where the real challenge with these children begin, right? So, it is a trio of hyperactivity and impulsivity and inattentiveness. So let us see what is hyperactivity. They say it is hyperactivity, but what are the symptoms which form a part of this hyperactivity, right? So it looks like there is if you see this child in the OPD also, just observe him. He is not able to sit in one place. He's constantly fidgeting, squirming, right? He has to move from the chair. He'll stand on the chair, go and try to climb on the windows or try to climb on the door, right? He's always on the go. He'll keep on moving in your OPD. He's not able to sit and focus with you. Leaves the seat constantly. You try to make him sit for a few minutes, also difficult. The parent has to sit with him tightly wrapped with his hands around, right? Excessively loud. They will come and blurt out. They will keep talking. Excessive talking is one of the common symptoms of hyperactivity. So these are the common symptoms. What is next is impulsivity. What is impulsivity? Impulsivity is generally these children, they do excessive talking wherever not required, right? They do not have any barriers. They don't know what to talk, what not to talk. Whatever is there in their mind, they're just blurt out. Even before you finish asking them something, they're talking something which is there in their mind. There is difficulty waiting for his turn. This is often seen in children in playgroups, right? In nurseries, where if all the children, when they have to play together, this child cannot wait for his turn. He tends to act without thinking. They do not know the consequences, right? Most of the times, a child climbs onto the door. He doesn't know that he will fall, he might get hurt. So these consequences are missing, right? So this is what is impulsivity. If something happens in the school, the child will just go and push the other child. This is also impulsivity, right? The third aspect is inattention. This is also very important. And what is commonly the presentation of inattention? A child who cannot pay attention to a task gets bored of a task easily, because what the parents say, this child is not studying. He doesn't like studies. But if you go and you analyze and you ask for all the symptoms, basically the child is not able to pay attention, or he is not able to concentrate on whatever is happening in the class. A child who cannot give attention to details. For example, he has to write something, right? Before finishing the question, he'll try to write something or scribble something. Understood? And he cannot follow multiple instructions. So one instruction, two instructions, he will do. But more than that, no, he cannot do because of the inattention. He cannot give sustained attention or mental effort. Anything which requires a little amount of effort, the child starts to escape from that activity. So maximum times activities when the children are made to do. So if it is easy, they'll fatafat finish off and they'll just go. But if it is a little challenging, they will try to escape. Then the parents say he always has to go to the bathroom. He has also always go to the park outside the classroom. So all these things are the general complaints. A child who jumps from one task to another without completing the first. So they usually, the parent, what they say, for example, if there are toys, he will play with one toy not even for 2 minutes. He has to change the toy immediately. So this is one of the symptom. If the child is watching something, this is another common presentation, something on the mobile, they say he cannot watch anything for even for a moment. He has to keep on scrolling it, right? He gets very bored easily. A child who forgets and loses things that are needed for the task completion. Maximum time this happens. The children, these children, they forget things in the school. Every day it has to be a new thing. So this is the picture of inattention. So we have seen the three aspects. It is hyperactivity, impulsivity, and inattention, right? And what else is needed? Like, we have to see in what scenarios this set of symptoms are present. Is it in the social area? Is it in the school classroom? Or is it at home? So symptoms should be seen in more than or equal to two settings. We cannot say that if at home the child is idle, so the child is more hyper. In school, is able to have a sustained concentration, he's able to do everything. So then the parents will say he's hyper at home, but that does not mean that the child has hyperactivity necessarily, right? So we need to evaluate in which scenarios the child is showing the symptoms. What is required for diagnosis? So this is, we have to diagnose it according to DSM-5 criteria for ADHD. So there are a certain set of symptoms for inattention, symptoms for hyperactivity, impulsivity. So more than 5 symptoms per category in adults, and if it is children, more than equal to 6 for more than equal to 6 months. Age of onset should be less than 12 years and more than 2 settings. And it has to have an impact on the child. In which areas? Social, that is with the friends, peer groups, academic, and occupational functioning, right? And you have to rule out all other mental illnesses or whatever, anxiety or anything else which could cause similar symptoms. Okay, so more than 5 symptoms, more than 6 months duration, less than 12 years onset, and impact in more than it has to be seen in more than 2 settings. This is the diagnostic criteria for ADHD. So what is the impact of ADHD? If suppose the parent, generally they see the impact, they say there is poor performance in the school exams, okay? There is problem with his friends, he does not have friends because everybody starts keeping him away, right? And low self-esteem. Gradually what happens as the child grows, he understands that he is not able to achieve these things like his peers and he develops low self-esteem. So causes and risk factors of ADHD. So let us ADHD. So let us see, now we have understood the presentation, right? So we have seen the trailer, क्या है उसके पीछे, behind the scenes we will see what is happening. So what is the pathophysiology of ADHD in children? First is the genetic thing, okay? Genetic inheritability. Second is the neurobiological basis, where there are certain changes in the brain structure and functioning. And the third, very important, is environmental and perinatal factors. So these three are the major risk factors for developing ADHD. So let us see what is there in each. So genetic factors in ADHD, it runs in families, right? So if you have a proper diagnosis of ADHD in the child, you can definitely see to it that father or the mother or somebody else in the family has such traits. 79% heritability is that high. Complex inheritance patterns, so that there is no single gene which is associated, which can be separated for causing ADHD. There is a 1 in 4 chance of either parent or sibling having ADHD. And what happens? The parent brings the child for treatment of ADHD, but in actually the truth is that the parent himself is having ADHD. So we need to see both the aspects, right? Associated risk with other neurodevelopmental and psychiatric conditions. So because of a genetic inheritance, it is also associated with other conditions. So we need to rule out one by one to come to a diagnosis of ADHD. Neurobiological structural factors. So let us see how is the brain in ADHD. Okay, so the volume of the brain in a child with ADHD is generally smaller. Okay, and there is loss of frontal and parietal cortices. Okay, and smaller cerebellar vermis. So these are the major changes which are occurring at the structural level in the child, in the brain of this child. Okay, and how does it affect the brain? So it majorly affects the prefrontal cortex, the reticular activation system, and the basal ganglia and the limbic system. There are 4 areas of the brain which are majorly impacted, causing symptoms of ADHD, right? So all the symptoms, we can trace back all the symptoms to affection of these 4 areas in the brain, right? What next? We saw what is the structural thing that has happened in the brain. Now, at the functional level, what is happening in the brain of this child? So, basically, we can attribute ADHD to deficiency of dopamine, norepinephrine. So, dopamine. So, why these children go to do something like adventurous things? They will always go make some sound, throw something, push somebody. They get that to seek for dopamine, right? Because of their deficiency, they get into such behaviors. Okay. Now, see, we have seen the basic presentation. We have finished the general genetic inheritability, the risk factors, and the pathophysiology, which is happening at the brain level and in the neurotransmitter level. Now, let us see what factors are there in the environment. Okay. So, prenatal environment is very important. Okay. So, maternal stress, drug exposure, undernutrition of the mother, These are the major factors, okay? Low birth weight in children or any history of trauma in children can also be seen in certain cases. So now, after seeing the genetic, next we saw the structural and functional changes, we saw the environmental factors. The fourth major factor, which very commonly we have to see, is the psychosocial factor in ADHD, right? This we can see and we can also address these things. So whenever there are disorganized family patterns, so most of the children who come to the OPD over there is always some history in the family that the father is a alcoholic, or the father stays away, or the father comes and he abuses the child or abuses the mother in front of the child. Okay, so these things are very common and we need to see in each case, is there any factor present? Okay, single parent or divorced parents, or the process of divorce is going on. Okay, growing up in foster homes away from parents, prolonged unattended screen time, this has come up mostly during the COVID period, after which many cases have come that till then the child's development was very normal. And then after prolonged screen exposure, they have gone for up to 7 to 8 hours of daily screen exposure for the child, especially during that developmental age of 1.5 to 4 years, right? That has also brought up symptoms like ADHD. So we have seen the four major risk factors which we need to keep in our mind. So these things we generally get in the history and we have to take care of each aspect when we see a case of ADHD, right? So inheritance common in boys than in girls, genetic causes, there are structural changes in the brain, neurotransmitter imbalance in the brain, which is the functional causes, then infertility and infertility treatment, majority. So these parents, generally they say that the child is born after a treatment for about 6 months or 1 year. They have taken infertility treatment, right? He has born through IVF or IUI. Maternal exposure to toxins during pregnancy. Suppose the mother had some infections, she had to take some antibiotics for a prolonged period, UTIs or anything else, okay, or any vaccination during pregnancy. Maternal stress during pregnancy, a very common cause again, where in rural areas or in semi-urban areas, even in urban areas also. So usually the family is not supportive, and that stress we need to understand, right? Premature birth of the child, low birth weight, childhood infections. Usually they give a history of recurrent infections in the childhood for which they have taken allopathy and they have then the symptoms have started. Head trauma is another cause which we have seen in some cases. Parental discords, very common. Single parent, even the parental discords. What happens is when the parents usually bring the child, both have to come, but sometimes only one parent comes, or sometimes both the parents will come and they will always keep complaining that the mother is not taking care, the mother is not taking care. That's why the child is having these symptoms. So, lot of discords are there, and we have to do a lot of counseling in these parents. Single parent, disorganized family patterns, and alcoholism. So, these are the general causes we need to keep in mind and inquire when we have a child of ADHD in front of us. This is another important thing, which is gut dysbiosis and ADHD. As we know, the gut-brain axis, it is not only the gut-brain axis, but the gut is the core cause for all the disorders, right? So there is a gut, it can give rise to heart diseases, gut-skin axis we have seen, where psoriasis, all these things aggravate, metabolic disorders, gut-lung axis. So similarly, the gut-brain axis is the root, right? Roadway for symptoms of autism, ADHD, all these things. So the brain, through the autonomic nervous system, it is influencing the gut microbiomes. And the gut microbiome, through the endocrine and neuroendocrine pathways, it influences the brain. So it is a bidirectional pathway. It could be the brain which is impacted first, and it results in changes in the gut microbiome, or vice versa. So this is the reason why we have to take care of the diet of these children, right? So same thing, brain, gut-brain axis, dysbiosis, and then it impacts the gut. Similarly, it takes place in the opposite direction also. So does ADHD come alone? No, it is a part of a package. So what is the package? Let us see what else is there. So it could be ADHD, or it can be with tic disorder, conduct disorder, mood disorders, anxiety disorders, oppositional defiant disorders. It can also be seen with autism, developmental delays, other genetic disorders, which could be functional or structural. Epilepsy is another common thing seen in these patients. Sleep disorders are very common in the children. So this is the entire package of ADHD. Now we need to see what is the exact scenario of the patient in front of you. So are there any diagnostic tools? We spoke of the diagnostic criteria. So is there any specific tool with which we can diagnose ADHD? Yes. There are two major tools: ADHD self-report scale, which is SRS, and Vanderbilt ADHD diagnostic rating tool. So these two things are very commonly used for diagnosing ADHD, and the results come as it is either hyperactivity at risk or inattentiveness at risk. So we understand where the child actually stands. Is it more of hyperactivity, impulsivity, or is it more of an inattentiveness in the child, so that we can address the issue properly. So then now we saw what is in the backdrop, right? We know behind the scenes kya ho raha hai bacche mein, what is happening in the child, what is happening, what are the genetic factors which have changed, what is the structural changes in the brain, what are the functional changes in the brain, what are the psychosocial factors and environmental factors we have to consider. So after seeing all this, okay, you now understood exactly, okay, this is the issue, this is the issue, this is what next. What next? So timely management is the key. Why? What if we leave these children? ADHD can, if the child is left without treatment, it can go into conduct disorder, it can go into oppositional defiant disorder, or anxiety disorder, or depression. Many children or many parents who stay in the rural areas without much awareness, they come at the age of 13 or 14, and where they are going towards ODD or conduct disorder, right? So if ADHD is caught in the early developmental stages, we can prevent the child from going into all these things. So hence timely management has to be done in these children, and the earlier the better. So now after all this, how do we approach these cases, right? So it is either an observation by the parent or any primary healthcare provider. Then the evaluation has to be done by pediatric neurologist or psychiatrist. Like it is, as I said, it is a package. So we need to rule out all the things. Is there anything else also lurking inside which we need to take care of, right? Then it has to be sent to a clinical psychologist for getting all the different tests done. With that, we establish a proper diagnosis. It is NDD, neurodevelopmental disorder. It could be ADHD with the exact magnitude of disease. What is the severity? How much severe? And then we have to plan proper interventional modalities. So whatever is required for the child as per the need of the child, we will be advising the parents. So this is the general approach for these children. What are the different therapeutic options? Now we know about homeopathy, right? But apart from homeopathy, what are the other things which are required and necessary in these children? So behavioral therapy, where they try to modify the behavior of the child by giving them positive reinforcement or negative reinforcement, right? Second is occupational therapy, to help them with certain motor skills or to help them with certain activities to keep them more active. Third is eating right, that is the diet, which is a major aspect of these children. And the last one is the conventional medicines, right? So these are the majorly used things. There are many more, right? But these are the things which are approved. So what is the need of the day? That it has to be an integrated and multimodal approach to ADHD. We cannot say that I will cure the child with homeopathy, right? Or I will cure the child only with behavioral therapy, or I can cure the child only with allopathy. No, it is not going to happen, because we have seen there are so many risk factors, so many aspects and facets to this ADHD cases. So we have to apply whatever is required at whatever point of time, right? So generally, this is what is followed where I am working in the setup. So it is a conventional treatment. Maximum cases, parents first go for conventional treatment, then they will come for homeopathy. That it was generally happens. And along with that, we have to take care of the diet, then PT, OT, that is physical therapy, occupational therapy, behavior modification, speech therapy if required, special education if required, vocational training. So these are the ancillary measures which are an important aspect of managing the children with ADHD. Okay. So what is the goal of treatment? Is it a curable disease? Now we have seen so many things. So is it a curable disease? We will see what happens in ADHD. The goal of treatment basically is reducing the problematic behaviors like self-harm, aggression, restlessness, or the hyper behaviors, so that afterwards we can enhance the adaptive behaviors so that the child is able to adapt to whatever situations he is exposed to: social skills, communicative skills, imaginative behavior. Then treating any comorbid conditions like epilepsy, GIT issues, insomnia, URTIs, tonsillitis, whatever may be the comorbid issue, we have to address that. Improving. So with all these things, what we are basically trying to do is improving the quality of life in all the spheres of functioning. And finally, we are trying to rehabilitate him. Rehabilitate in the sense we are trying to make him so adaptive that he is almost fitting into the main society. So this is our aim of treatment. Okay. So what is the need for homeopathy? So we have so many other therapies, we have diet modification, we have medicines in allopathy. Then is there a need for homeopathy? Then in allopathy, they use stimulant medications like Ritalin, which is beneficial but has a lot of side effects. Okay. And dependency comes up in these children, or the parents generally say that we started with the medicine, but he's becoming so dull that he is going and sleeping in the school, or he's becoming so dull that it is very difficult to get any activity done from the child. We don't want our child to be so dull. Second thing is behavioral therapy becomes a challenge as the child is either inattentive or too restless. So therapists, what they generally say, if we send them for therapy outrightly, if the child is coming to me for the first time for the treatment of ADHD and I tell them go and start with therapies, so immediately what they will say, they will say that the therapist said you first take medications to reduce the hyper and then we will start with the therapies. So that is what. So that is a small uh, thing which we have to keep in mind. So we have to take care of the hyper first. Dietary modification often has very good results, but these are temporary. And compliance, like if we say you don't have to take sugars, you don't have to give this, there are many things which we avoid in these children. GFCF diet is generally followed, that is gluten free and casein free diet. So then the parents' problem is that it becomes very difficult because as it is, the child is very picky in eating his food. Okay. So if we remove all these things, he loves roti. What if we don't give roti to him, right? So that becomes a challenge for the parents. So what makes homeopathy popular for ADHD? And when there is no improvement with conventional treatment and therapies, and when there are side effects of conventional treatment. So these are the patients who usually come to us for homeopathy, and they are very easy to administer. Okay. So now we have seen about the presentation behind the scenes, then we came to understand what is the goal of treatment, what we need to achieve after treating or while treating these cases. We have seen how to approach these cases in a general way. We have seen why homeopathy is required in these cases and how it has to be collaborated with other treatment modalities. Now let us get into the deeper level, right? What are the challenges faced during homeopathic management of ADHD cases? So first thing is, as I told you, the child is squirming, continuously moving, roaming. The parent has to sit with the child. It becomes very difficult for getting a proper history. Difficult in getting regular follow-ups. General notion in the parents, कि first time we are taking the medicine for 1 month, they'll try, कुछ result नहीं था madam, so we stopped. Or they'll take for 1 month, they had a good result, they continue for 6 months and they then turn up after 6 months. कि madam, we have used the medicines, it was better. So either this way or that way, both extremes are seen. early and easy dropouts. If results are not seen in the first few follow-ups, right? They want to see some change or the other, which is a ray of hope, of course, for these parents because they are troubled and tortured in this way. So they don't tend to continue if you don't give any result in the first few follow-ups. Taking multiple treatments simultaneously, yes, they will hop from one treatment to other, or they will try all the things together. Homeopathy we have, conventional we have to do therapies also. Then they'll do some other treatments also. Ayurveda they'll take. Match our expectations in RRF. So we have our chart. Ki first is may if it is same status quo hai, then what we'll do, we'll still wait because we have given a constitutional remedy. Third time also, if the child parents is slightly the appetite is improved, we'll again give SL and we'll again wait. But what happens in those 3-4 months? The child's hyperactivity has not changed a bit. So then the parents feel, but our expectation is what? Okay, generals are getting better, sleep improve hua hai, appetite improve hua hai. That means the child has to improve. But what the parents' expectation is that hyperactivity is not changed a bit. So they will not continue treatment because they don't understand what is our RREF, right? So generally, this case taking is slightly different from our routine case taking because it is more of a pediatric case, and that too in children with such behaviors and such varied background, right? So we need to understand each and every aspect. So first thing is the presenting complaint, as we do in each case, right? So understand the presenting complaint, evolution of the complaints like ODPP, so onset, duration, progress, pace. So all these things we have to consider and note down. Then what are the associated symptoms or concomitants? So then they'll say, okay, the child has recurrent tonsillitis, or the child has constipation, or the child has loose motions, or he has sleep issues, lot of sleep issues, okay? Or he gets scared very easily. That is also another thing. Anxiety is there in these children. So these many, it's a whole list of associated symptoms. We need to consider those also while taking the case. Consanguinity, if the marriage is consanguineous, then there are again chances, the prognosis changes with that, right? History of conception, as I said, because IVF, IUI, infertility, or a history of abortions, all these things are playing a major role in development of the disease. So how is the pregnancy? So how was the state, mother's state during pregnancy? Any infections, toxins, vaccines, all these things. Birth history. Was it a natural birth? Was it a cesarean or normal delivery? Birth cry, birth weight, all these things will come in the birth history. Milestones, another major thing in these children. So we need to understand where the milestones are either the developing normally, a little delayed, or completely haywire. So we need to take care, and we need to also ask if there was anything which happened just before. Suppose the child rolled well, okay, on time, then he was sitting on time, and then suddenly something happened, and then later on the milestones delayed, or everything was on time till they gave a vaccine, and after which the speech was regressed or the speech was stopped or he did not develop speech. So these things are the common presentations where the parents will tell you this. Vaccination history, family environment during pregnancy, early years of childbirth, parenting style is very important, past history of the child. For we have to understand whether there are any suppressions, infections, anything, or any history of medications, surgeries. Family history, very important to understand the evolution of miasm in the family. Physical generals, yes, because this being a mental disease, we have to give more importance to the physical generals of the child. Medication history, history of any therapies, and the dietary habits. Most of these parents, they are freely giving the child whatever should not be given and what should not, what should be restricted, right? They give them juices, chocolates, ice creams, everything. So we need to educate the parent on the right diet. So what are the pillars of totality? So how do we form a totality in ADHD cases? So first we have to give importance to any causative factors or triggers, which could be trauma, which could be infections, vaccinations, suppressions, toxins, or any emotional causes, right? It could be either during pregnancy or after the delivery of the baby. Mental state with reaction of mother during the pregnancy. Physical concomitants or comorbid diseases. So we understand the sphere of action. Suppose mind, brain is affected. Along with that, he has some other complaint. So suppose polyps are there. So we understand the different areas of weakness, predispositional things in this child. Physical generals and mental generals, milestones, characteristic mental symptoms, peculiar behaviors which are observed in the child, past history and family history. We need to understand the evolution, and we need to understand in terms of dominant miasm, which is predominantly seen now, and the fundamental miasm, which is in the background of the patient. So it could be SORA, psychosis, tubercular of. So we need to understand if generally these children, the presentation is tubercular. So if it is with psychosis, what could be the presentation? If it is with syphilis, what could be the presentation, right? So that is why it is important. Homeopathic medicines. So these are the general medicines which, okay. So this is the different medicines which we can use. So acute medicines, we understand we have to manage the acute or the phasic things. Suppose the parent says that this child suddenly he gets aggressive, suddenly he starts beating everybody, he doesn't allow anybody. So if you are able to match a phasic remedy, give it to the child. Maximum times I have seen medicines like chamomilla which help to bring down the acute behavioral issues. Constitutional medicines, nosodes, right, for addressing the genetic inheritances in the child. Okay. Isopathy is used for detoxifying the adverse effects of drugs or vaccines. Mother tinctures, yes, we have good mother tinctures which can help backflow remedies to calm down the troublesome mind symptoms. So these are very commonly used medicines which I have used in the practice. So tuberculinum is there when ADHD with Down syndrome or congenital disorders or hydrocephalus, whenever there is a history of TB in the personal past or family, consanguinity is seen, hyperactivity with hypersensitivity, with maliciousness in children. Maliciousness means what? They'll just try to kill insects, or they'll try to trouble somebody, right? Destructiveness, stubbornness with congenital disorders. This is another indication for TUB. Aggression with affection, they're always better by traveling. Genetic disorders, structural deformities with ADHD, ADHD from parental domination, because of which the child is turned into a destructive child or has tendencies with a poor immunity. So TUB works well in all these conditions. Carcinosin with congenital disorders or with genetic diseases, history of cancer or autism in the family, consanguinity, autism in the sense any neurodevelopmental disorder in the family, consanguinity, children with parental domination or over expectations. The child is mild, he is not a destructive like TUB. With congenital disorders, with genetic disorders, with poor immunity, you can think of carcinosin. These are the general indicators. Like with this, we have to see the basic nature of the child also. Sulfur, ASD or ADHD with bowel or bladder dysfunction, it generally works well in these children. In selfish children, in dirty children, lazy, lethargic. So generally sulfur works well in these children. Puja, from bad effects of vaccination. If the parents say that, yes, after vaccination, this thing has happened, I don't hesitate to give Thuja as the opening in the case. And it really gives good results. Syphilinum, ADHD with congenital disorders, with genetic disorders, with birth defect works wonderfully. So I had one case of syphilinum wherein the child was moderate ID with deafness, congenital deafness. Based on that indication, I had given syphilinum, and after that, the parent reported that the child was able to hear when they used to call in a loud voice. So these remedies really work wonderfully in the cases if the miasm is there in the backdrop. Tarantula, ADHD with lot of hyperactivity, destructive tendencies, escapism, and ailments from parental domination, lack of love and affection in cunning children. So there is slight difference between TUB and tarantula, right? So as we see the patients, we understand the minor differences. Hyoscyamus, ADHD with foolish behavior, giggling. Some of these children, they present like that. They sit sillily in the chair, they are laughing, self-laughing is there, giggling is there. They are in that game mood. Self-talking, gestures, laughing loudly, symptoms of regression. Like some children, they start, okay, some children, what they'll do, they used to do something on their own, they stop doing that because they want the parent to do it, right? So that is a something like for seeking attention, parental attention. Jumping behavior is there, handling of genitals, humming or making sounds, eating and drinking dysfunction. It helps in these cases. Stramonium with speech issues, wonderful remedy for speech issues with lot of gestures, lot of using hands in gestures. They continuously keep playing with the hands. Hand flapping, handling genitals is seen in stramonium also. Lachesis with prominent loquacity and history of jealousy. Belladonna with echolalia with history of febrile convulsions, lot of aggression, self-hurting behavior, head banging, violent temper tantrums, biting, tearing, and the parent says that a child becomes hot when he is aggressive. Calcarea phos is a beautiful remedy, which is very commonly used by me. With stubbornness, with stereotype. Stereotype is doing the same things again and again. Prominent sensory patterns with delayed speech, developmental delay, with speech regression. Regression is the child developed speech, but it went back. He stopped using all those words. With phosphorus-like features and speech delay. Zincum phos and calcarea phos come very close. Zincum phos with suppression of discharges, eruptions, delayed speech, repetitive speech, fidgety feet, excessive appetite, phos-like physical features with mental delay or slowness. That is zincum phos. Other commonly medicines which we use are ethusa. One beautiful case wherein the child was using constitutional remedy, but not with great results. So then when we inquired into the history, we came to know that there was a history of severe it was typhoid with dengue, and the child was admitted in the hospital for 1 month. Okay, and after that, everything, all the symptoms of ASD and ADHD were seen. So, history of suppressed gastric disorders, and so this was the entry point for me, and I started giving the child ethusa along with the constitutional, which helped wonderfully. Arsenicum album, hyperactivity, chilliness, recurrent colds, fastidiousness. Calcarea iode, calcarea-like features. Patient is hot. It is a glandular remedy. So tonsillitis or anything like that. And restlessness is there. Chamomilla, hyperactivity, not satisfied when he gets the desired things, does not know what he wants. Okay. Other commonly used remedies are Sina, Passiflora. Passiflora in mother tincture form, we need sometimes Califos. Biochemic Coffea cruda jalapa, they used for sleep issues. They work wonderfully. And Lycopodium in intelligent children. So now we have seen the case taking, we have understood, we have given some remedy. Now what next? We have to see what to do at the follow-up, right? The parent has come to you after taking a medication for 1 month. Okay. So what is there? Either the symptom has changed or it has not changed. New symptoms have come. Okay. The parent says that, okay, the symptoms are same. Okay, we'll take an action. We'll either repeat it or we'll change or do something, right? If they say the new symptoms have come, child has become very aggressive, what will you do? We should not directly jump to changing the remedy or thinking of some phasic remedy. We have to keep these pointers in mind. Is there any change in dietary habits? Yes, the parents say, yes, we traveled somewhere in the function. There he ate all kinds of sweets and everything. So that is one cause. Inadequate sleep. Yes, because of the routine or something, the child is not sleeping early and he has to get up early for the school. So he hardly has any sleep. Improper bowel movements is another important cause. If the child is having constipation, not passing stools every day, or that has come down, okay, so that also causes increased crankiness or irritability in children. Change of place or environment. Yes, they go to the native place and then they come back. When again the symptoms, they are seen to increase. Screen time, unattended screen time. Oh, yes, child is watching screen and we are giving medicines. We won't see any change. Family discords. Okay. Sometimes the child comes to me that there were these two twins were there who used to come to the clinic OPD, and the child used to come and she used to blurt out everything what has happened in the family. They were doing well and suddenly she comes, she starts crying, "Ma, Papa ne mama ko mara tha kal raat ko aise ho gaya karke." So it impacts the children, and then the parents come and tell me, yes, inka hyper zyada ho gaya hai karke. So we are able to link these two things. Any history of infection in the interim period between your first this period when you are taking the medications. For that infections, if they have used any antibiotics, this also tends to increase the symptoms for some time. So we need to immediately give something to reduce those symptoms, like sulfur or Naxomica if antibiotics have been used. So that we are removing. Parental counseling. So what we should do? So for addressing these things, we need to talk to the parents, counsel them. Behavior modification techniques we have to teach the parent. We have to promote physical activity in the child. Most of the times the child is just sitting in the school, then in the tuition, then he sits and he does some work, activity. So basically, there is lack of physical activity in these children. So we have to keep telling them, okay, 1.5 hours, the child has to play out, right? Avoid improper diet, promote good sleep, parenting style. So after considering all these things, if the new symptoms or the aggravation of symptoms is seen in spite of waiting for a follow-up or two, then we will address those symptoms also, right? But all these things have to be kept in mind without before we jump to change of medication. So ADHD is a spectrum. It itself is a spectrum, right? From no ADHD. What I mean by no ADHD is sometimes the parents, they bring the child is not studying, okay, and घर पे बिल्कुल पढ़ाई नहीं करता है, घर पे कुछ भी, he doesn't study, and then when we talk to the child says, no, I get good marks, I study, but the parents are not listening to me, they are not allowing me to go to play, they want me to study at home also. So who has the problem here? It's not the child, right? But we are seeing aggressive symptoms in the child because of parental pressure. So it's not ADHD. And the other extreme is ADHD with genetic structural irreversible changes. So we have a whole lot of ADHD variants in between. This is the spectrum, and based on this, it will decide the prognosis of the child. So with all this, so this was the basic backdrop which I wanted to explain. So we have seen all the aspects and we have seen the entire picture of ADHD now. So let me share my experience through cases. Okay. So this is patient master XYZ at 5.2 years, male. He came with the chief complaints of poor attention span with sitting tolerance of only 5 minutes, poor concentration, poor eye contact, echolalia, that is repetitive speech, inability to follow multiple instructions. They don't have the patience to listen to the instructions, obstinate, very stubborn, temper tantrums, banging head whenever angry, sensitive to sounds and textures. And the behavior at school, trying to hit children, very aggressive, tends to pass stools only in the diapers. This was the major concern of the parent. At 5.2 years, he has to be put on diapers only when he has a bowel movement. Bedwetting is seen in this child. Past history. After his birth, he was brought up by his grandparents and father due to the mother's work priorities for a period of 9 to 10 months. During this period, he was also vaccinated. And later, he developed influenza and was seriously down with loose motions and fever for 1 month. He was given a lot of antibiotics during this period. This is a typical history which the parent has given. Mental generals, he is generally a very affectionate and caring child, intelligent, talkative, fear of reprimands, and temper tantrums. These are the major characteristics. At the physical level, he is thermally chilly. He has a craving for cold drinks and ice creams. The child would enter the OPD with a smiling face. And whenever I would ask anything, he would reply something irrelevant, broken words, unclear speech, shy. So we can see the shyness in the face. He tries to answer, but in small voice, broken words, not very clear, and not relevant also to whatever you are asking. So that is the major thing. Okay. Mother's history during pregnancy. So this is the next important aspect we need to inquire. So mother's history was uneventful. Obstetric history, there was a single live birth 5 years before this child. So this is the second sibling. Physical milestones normal except for speech which was delayed. Past history at 9 months age, this child had history of influenza with prominent continuous loose motions with high grade fever. Vaccination history, he has been vaccinated. So we do not exactly know whether that was vaccination or the influenza as a trigger. Mother has hypothyroidism, father has asthma, paternal uncle and grandfather suffered with cancer. These are the scores. CA is nothing but his current age, chronological age, 5.2 years. His developmental age was 2.9 years. He's almost 2 years lagging in development. Social age is 2.7 years. Developmental quotient is 66. Social quotient was 62. So these are the assessment values which we generally get. So ADHD with mild ID and mild ASD. homeopathic diagnosis, chronic miasmatic mental disease. Miasmatically, fundamental miasm is psychosis because of the history of suffering asthma, hypothyroidism, and cancer in the family. Dominant miasm is tubercular. Totality which I have taken is hyperactivity with fear of reprimands, hyperactivity with temper tantrums, with aggression, with speech delay, with sensory issues, craving for sweets, craving ice creams, chilly, and disposition is affectionate and mild. Okay, so the remedy which was given was calcarea phos in this case, and interconnect remedies. I have started the case with thuja, then tuberculinum, and other remedies as and when required. I have used in between stramonium, hyoscyamus, ethusa. Ethusa, as I said, because there was a history of influenza, gastric disturbance, which can cause impact on the brain. So with that indication, I have used ethusa also in this case with wonderful results. So this is what we have seen. Now problem areas in this child before treatment and after we started treatment. This is at the end of 1 year. So behavioral symptoms, aggression, it has come down. Striking, not seen now. Restlessness, now it is seen only when he is idle at home. Repetitive behaviors like hand flapping, rubbing genitalia, it is very occasional, only when watching TV. So when the child is idle, these things come up. Higher function, sitting tolerance, which was only for less than 5 minutes. Now he is able to sit at school for up to 6 hours and therapy centers for 2 to 3 hours. Attention span was poor, now it has improved. Comprehension and understanding, couldn't follow instructions, right? Now he's able to follow 3 to 4 instructions at a time, no bedwetting, attends the washroom for stools. But the diaper thing has also gone off. Echolalia, repetitive speech was there. So when you ask, what is your name? He will sometimes say, what is your name? He doesn't know what to answer exactly. Speech improved, eye contact improved. Sensory issues to sounds, textures, it is not seen now. So these changes we are able to see in 1 year. Okay. So this is the final assessment value, which is we have done recently. So at the start of treatment, it was 5.2 years. Now the child is 7.8 years. Mental age was 2.9 years. Now it is 7.3 years. So he has patched up with that lag now. ESA was 75. Now the ESA is 65. IQ 66 to it has come up to 94. Intellectual impairment of 50% was there. Now it is 0%. Now the child is going to normal school. Certain issues do come up, but counseling has to be done to the parents. So this is the paper. So this is the first case. And the parent was happy, so she has also given consent for videos and everything. So she has written that due to vast improvement, there is no objection for me for presentation of son's video for academic and educational purposes. So that was the impact homeopathy, and that child was going for therapies before our treatment started, but he was not responding to that. From school teachers, he is much better than other kids in the class, no issues at all. From the therapists, he doesn't need speech therapy or special education anymore. From parents, he has much improved with homeopathic treatment. The only symptoms remaining are his aggression seen on the mother when denied something, or his restlessness seen when he is idle. But he is able to cope up in academic area, with his friends, and at home. So all three areas he is doing fine and able to adapt. That is the first case. Quickly, I'll go through the second case. I'll complete it. So, 5.4 years old child was brought with a complaint of irrelevant talk, self-talk, hyperactivity, constant roaming, cannot sit in a place, always doing contrary to what has been told to him. Okay. Aggression, screaming, beating, fear of cats, dark, loud sounds. He gets irritated and closes his ears. Obstinate and demanding, but gets diverted easily. Gets scared when reprimanded, shivers. So, intensity. He is a pampered child. He craves attention. He doesn't allow his mother to talk over phone. Will do something to seek her attention. Physical generals craving for sweets, non-veg, ice creams, cold drinks, eggs, chili. He has a large head due to hydrocephalus. Keeps roaming. Whenever you ask anything, he gives irrelevant answers. Blurts out before being asked anything. Keeps talking some or the other topic, right? So continuously has to talk something. Whatever is in his mind, he will talk. Whatever he has done in school, he'll keep on talking. Even though we are not asking him, or we ask him something, he's giving something which is going on in his mind. Okay, that is the talk. Birth history, full-term LSCS, birth weight 2.5 kgs, cried immediately, neonatal jaundice was there, loose motions at 6 months of age, First year got febrile convulsions with 104 degrees fever. Okay. So high fever, another indication for tubercular miasm. Infertility, IVF conception, as I have said, this could be the risk factor. Tried IUI for 6 months. Developmental milestones, all the milestones were delayed in this child. Investigations. Now this is ADHD on the other spectrum with a lot of structural changes in the genetic structural changes. The signs of communicating hydrocephalus, thinned out corpus callosum, cerebellar malformation. Then bilateral optic atrophy, hypoplastic inferior vermis, prominent cisterna magna, genetic evaluation, chromosome 29, microdeletion syndrome. So if we see, this is ADHD presentation with a lot of structural changes. Psychological assessment, this was done when he came for treatment in 22. 5.4 years, 3.10 years was his social age. So there is a lag of 2 years. Developmental age was 4.3, lag of 1 year. ADHD with borderline developmental delay with hydrocephalus. Paternal grandfather had DM, mother has primary infertility on Accepta 10 mg. So he has been taking allopathic treatment since 4 months before coming for homeopathy. So diagnosis ADHD with borderline developmental delay. Homeopathic diagnosis chronic miasmatic mental disease. Miasmatic diagnosis psychosis. Tubercular is the dominant miasm. Totality of symptoms. Craving for sweets, cold drinks, non-veg, eggs, chili patient. History of loose motions, febrile convulsions. Hyperactivity, desire for company and desire to touch. So he is always likes children and he will go and touch them. He will try to push them to seek their attention. Hyperactivity, developmental delay with timidity, with sensory issues, with hydrocephalus. Again, this remedy, calcirafos was given and intercurrent was TUB. So if we see before homeopathic treatment, the anger pattern which was there, throwing things, beating, getting excited, pulling them, contrary behavior, it has come down and seen occasionally now. Higher function, sitting tolerance, which was less than 5 minutes, he is able to sit in a full-time school for 6 hours, followed by tuitions for 2 hours. Irrelevant, excessive talking, talking loudly. Now he talks relevantly to whatever is asked for. He waits for your question. Understanding poor for academics, complex instructions. Now it has improved to the extent of asking doubts in schools. He is able to comprehend what is happening in the school. Sensory issues, closes ears at loud sounds, getting irritated. Now he doesn't react to such sounds. These were his values and this is the current value, which is done recently. So he was 5.4 years, now he is 8 years. 3.10 years was his social age, now it is 7.9 years. Developmental age 4.3. So that lag has been patched up. 72 was his social quotient, now 80. Developmental quotient is almost the same. So in this, what has happened is, though he has been in allopathic treatment, they have stopped, the parent has stopped the allopathic treatment for, in the meantime, for a month or so, they had stopped and seen, and the child was able to be managed even without allopathic treatment. So this is his case. These are the current values. So this is the general role of homeopathy in ADHD. Helps control hyperactivity. We have seen in both the cases. Helps improve the attention span. Helps bring down aggressive behavior. Helps develop cognitive and speech changes. Enhances other physiological functioning like sleep. Improves immune functioning. Right? So the children who are prone to infections or all those things, that also comes down after a year or so. So overall, what are we helping with homeopathy? It reduces the parental stress, reduces the burden of disease, improves the quality of life of the child and the family as a whole, and gives hope and strength to parents and also to us, right? So this is all from my side. I would like to convey my gratitude to the college and everyone for listening patiently.
Just a minute, madam.
Yeah, ma'am. So any questions or anything, ma'am? Actually, we had the videos, but because it is being shown on YouTube, I am not able to show those now.
Good morning to our respected speaker and our participants. Now I would like to thank our esteemed speaker Dr. Annapurna for sharing valuable insights on homeopathy in treating ADHD in today's webinar. We appreciate your time and expertise, and I also thank to all the participants for joining in and engaging the session. With your presence, we made it successful. Thank you.
Okay, thank you, madam. We'll end the session, madam.
Thank you, ma'am. Thank you. Thank you so much for giving me this opportunity.
Thank you so much, madam.
Yeah, ma'am. Can we leave, ma'am?
Yes, you can leave, madam.
Yeah, thank you.